So hello and welcome to this webinar on MedDRA coding basics. I'm Carol Wilson and work as a medical officer at the MSSO and will be your instructor today. And I'm joined by my colleague Leander Mold, who has been speaking to you before. We both will take you through this webinar that will take around 2 hours. So we have plenty of time for exercises, demonstrations, and also for addressing your questions. And as Leander has already mentioned, please submit any questions you may have during the webinar through the question panel that you can find in the control panel of the GoToWebinar application on the right hand of your screen. And I will allow as much time as possible for questions both during the course and also at the end of the presentation. Now let's start. Many of you will already be familiar with the content of the slide. ICH adopted the development of MedDRA in the mid-90s and became the owner of the terminology. ICH then, on contract, appointed the MSSO, the MedDRA Maintenance and Services Organization, to take care of the maintenance and further development of the terminology based on user feedback, to provide and organize corresponding training, and to administer the MedDRA licensees. And all these MSSO activities are overseen by the ICH MedDRA Management Committee. ICH is not only the owner of MedDRA, but also owns this training material that we will be using in this webinar. It is protected worldwide. You may use the slides with the exception of the MedDRA and ICH logos, but will have to clearly indicate that ICH owns the copyright. Also, any adaptations of the slides have to be clearly labeled. The second bullet point refers to warranty and liability issues you should be aware of, and the third bullet point is not relevant for today because we will not be using any third-party slides. Now let me provide you with an overview on what we will cover today. At first, we will shortly address the topic of MedDRA structure and characteristics. We will then discuss the need for coding conventions when using MedDRA and look into an important document you should make yourself familiar with, the so-called Points to Consider document for MedDRA term selection that provides principal rules for MedDRA coding. We will then learn about the functionalities of the MedDRA browsers that are provided by the MSSO. You can use them for free in the framework of your MedDRA license to browse the terminology and to look for appropriate terms for coding purposes. And I will demonstrate how to use the browser to search the terminology. After that, we will go through some coding examples using the browser, just demonstrations, and you will be able to try some coding with MedDRA yourself and provide your own suggestions at the end of the session. And we will conclude with a question and answer session as mentioned already, but we will address your questions throughout the session as well. The next two slides explain about the polling that we will be using during this webinar. Leander has mentioned already that we will use these questions during the whole course. If you would like to join these quizzes and participate in the examples today, there are two ways to do so. The easiest way is to scan this QR code with your smartphone or tablet. It will bring you directly to the first poll question. Or you may enter the indicated web address into the URL bar at the top of your internet browser in your computer, tablet, or cell phone, and it will then, so here it is, paulf.com, and it will take you to a log-on screen and you'll be asked for a username. The poll is completely anonymous, so you don't need to enter your name, but enter my name as the username, Carol Ann Wills 584 with no spaces. Here it is. And nothing more has to be entered, just click join then afterwards. And Leander has put these credentials in the chat as well. Please, you don't have to get under time pressure because you will be able to see these credentials on each slide that relates to the quizzes. Now let's see whether this technology now works. Oh, it seems so. I see MedDRA users from the US, so it's very early for you. People in Europe, many in Europe, Spain, Portugal, buenos días, bon dia, Italy, buongiorno. Otherwise, it's really crowded. So Scandinavia, South Africa is with us. And what is it there? I see Iran. I see Egypt, maybe, Russia, Dobry dzień, Philippines, South Korea, somebody in the middle of the Indian Ocean, India, of course. So nice to meet you all and happy to have you all with us for this webinar today. So our quizzes seem to work. So let's start. The basis for accurate MedDRA coding is a good knowledge, of course, about MedDRA scope, its structure, and its characteristics. So let us now start with one general question. What do you think are the benefits of using MedDRA? Why was the implementation, the introduction of MedDRA an important step in pharmacovigilance? Harmonization, standardization, structure. Not sure yet. Yes, you're a newcomer. Common terminology, common language. Exactly. Standardization. It is all about harmonization, standardization. Well done. Thank you. So with the standardization achieved with MedDRA, we are now speaking the same language when talking about safety data from pre-marketing in clinical development to post-marketing in pharmacovigilance. MedDRA has replaced legacy terminologies like CoSTART that was mainly used in clinical studies and HUART that was mainly used in post-marketing. It is not only used by the biopharmaceutical industry, but also by many regulatory authorities around the globe. Today we will be focusing on the data entry aspect, the operational coding part. But MedDRA also has features that support data retrieval and analysis, as well as presentation of clinical safety data. This whole topic is addressed in separate webinars. One is called Data Analysis and Query Building with MedDRA, and the other one introduces the standardized MedDRA queries or SMQs that are used for data retrieval of MedDRA-coded data. This is a key slide that shows what is in the scope of MedDRA or what type of medical terms is covered by MedDRA. In the blue circle, you will find all medical terms and conditions that are within its scope. It incorporates terms for medical conditions like diagnosis and clinical signs and symptoms, terms for indications for use, investigational tests and results, medical and surgical procedures, terms for the medical, social, and family history of patients, terms for medication errors and product use issues, terms for product quality and device-related issues, pharmacogenetic terms, as well as terms for toxicologic issues, and last but not least, the scope of MedDRA also includes the standardized MedDRA queries that are used for data retrieval purposes that I've just mentioned. On the other hand, MedDRA excludes terms that relate to frequencies, unless such information is medically relevant, like frequent micturition or frequent bowel movements, for instance. This same applies to indicators for severity. you will only find a few of them on PT level where clear medical definitions exist for the characterization of the condition, like in the case of PT severe acute respiratory syndrome, SARS. You will not find any numerical values for investigational results, but qualifiers like normal, abnormal, increased or decreased or positive, negative. And patient demographic terms related to race, gender, age, etc. are excluded, again with the exception of terms where information regarding age or gender is relevant based on medical considerations, like for instance when it comes to male or female infertility, male or female breast cancer, infantile acne, or neonatal jaundice, for instance. So here you would find specific terms that include demographic information, but you won't find them for each and every medical condition. MedDRA is not a drug dictionary, nor is it a medical equipment, device, diagnostic product dictionary, meaning that you will not find any brand names in the terminology, but there are several terms that include generic drug names, like for instance the PT thalidomide embryopathy. And you won't find brand names of devices, but terms for specific device types like catheters, joint prostheses, cardiac pacemakers, etc. And finally, it does not contain any terms that refer to clinical trial, clinical study design, like double-blind, placebo-controlled, etc. Let us now shortly look at the structure of MedDRA and how MedDRA is organized. MedDRA has a systematic 5-level hierarchical structure, starting with a system organ class or SOC on the top that groups high-level group terms, HLGTs underneath, and these then group the high-level terms, HLTs. Under the HLTs, you will find the preferred terms, the PTs, representing the medical concept level. The PT level is used for data retrieval, for data presentation, and for data analysis. And the PTs then group the LLTs, the lowest level terms, that are used for data entry and operational coding. And you can see that starting from the top, 27, MedDRA gets more and more granular and specific. That is from the SOCs down to nearly 90,000 LLTs. So for coding purposes, you would browse MedDRA to find the most specific and accurate LLT for the reported medical condition of interest among these nearly 90,000 LLTs. Please note that British English is used at the PT level and above. It is only on the LLT level where you would find terms in American English. So if you would look for a specific preferred term and use American English when searching for a PT, you would not get any results, because here on PT level only British English is used. Here are the 27 system organ classes. Some system organ classes group terms based on their manifestation site, like blood and lymphatic system disorders, hepatobiliary disorders, renal urinary disorders, excuse me, vascular disorders. Other SOCs group terms based on the etiology of the respective conditions, like for instance, the SOC immune system disorders, or infections, infestations, or neoplasms. SOC product issues groups terms that relate to product quality issues. SOC investigations and surgical and medical procedures group terms based on their purpose. And the SOC social circumstances is a special one. It contains terms that describe the social context of patients, like lifestyle issues, family issues. Please note that terms from this system organ class should normally not be used for coding adverse events, rather for coding medical history of patients. So you will need a good understanding about these SOCs and their content in order to get a better feel on where to search in MedDRA, in the MedDRA hierarchy, to find the most specific medical concept or term. Let's look at an example for the MedDRA hierarchy. In this instance, we are looking at the SOC cardiac disorders. And this SOC cardiac disorders contains 10 HLGTs, representing the main types of cardiac disorders. So here we have selected the HLGT cardiac arrhythmias. Under this HLGT, there are several HLTs grouping PTs for the different types of arrhythmias, like supraventricular arrhythmias, ventricular arrhythmias, etc. The HLT shown on this slide is HLT rate and rhythm disorders, NEC. NEC standing for not elsewhere classified. NEC groupings are only found on the HLGT or HLT level, and they represent miscellaneous groupings of terms that do not fit into any other HLT or HLGT. And here we are looking at one PT that is grouped under HLT, rate and rhythm disorders, NEC, that is arrhythmia. And this PT now groups a number of LLTs that are not all shown on the slide, just a selection of them. The LLTs now represent synonyms, quasi-synonyms, or lexical variants of the PT term, and also colloquial, patient-friendly terms. The LLT level is the data entry level, and the granularity on the LLT level provides guidance to medical coders and thereby also facilitates accurate coding. Now let's look at the LLTs under PT arrhythmia that are shown on this slide. Arrhythmia, NOS, stands for arrhythmia not otherwise specified. Now it doesn't make really a lot of difference whether you select arrhythmia NOS or the LLT arrhythmia, but it is good practice only using the NOS terms when it is explicitly reported that a given condition could not be further specified. So if just arrhythmia is reported without any further information, it would be good practice to select LLT arrhythmia and not to assume that it is a not otherwise specified, an NOS. LLT dysrhythmias represents a synonym for arrhythmia, and some of the LLTs are labeled non-current, like here, the LLT other specified cardiac dysrhythmias. It is marked in red, and this is also how the non-current terms are highlighted in the MedDRA browser. So non-current terms are only found on the LLT level. Very important to remember. Non-current terms only on LLT level. LLTs are set non-current when identified as ambiguous, truncated, so not following the MedDRA naming conventions, ambiguous, misspelled, and not following other MedDRA rules like in the case of combination terms, where two different PTs exist in MedDRA in order to represent the given condition. They are flagged as non-current and should not be used for ongoing coding. They are not removed from the terminology in order to preserve the information from legacy cases, meaning that if you have logged a clinical database in a previous MedDRA version, you would still be able to find these terms, although they were made non-current, and you could then map them to a better term when upversioning your data. An example for non-current for a non-current LLT is the co-star term nausea and vomiting, representing a combination term that is represented by two separate PTs. It has the non-current status, and it is grouped under PT vomiting. Another example would be the ambiguous term angina, a term that is most frequently used to describe angina pectoris, but that may also relate, of course, to angina tonsillaris. Now here comes the next question for you. Which of these LLTs do you think are non-current in MedDRA? Which of these LLTs you think have the non-current status in MedDRA? MI, insomnia with sleep apnea, bloody drainage, abdominal bloating. I see you voting. Which have the non-current status in MedDRA? Let's see what you're going for. Yes, you're fully right. All of them have the non-current status. Let me close the poll. So MI is usually used to describe a myocardial infarction, but it's an ambiguous abbreviation because it could also relate to mesenteric ischemia, mitral insufficiency, or mental illness. Drainage seems to be a clear term, but drainage could be a surgical procedural term referring to the systematic withdrawal of fluids, or it could relate to a non-surgical term referring to a discharge or secretion used for the excretion of liquids from the body. Insomnia with sleep apnea is a combination term that is, and insomnia and sleep apnea are two separate PTs in MedDRA, and abdominal bloating, of course, is a truncated term not following the MedDRA naming conventions, and that's why it has the non-current status. So well done. Thank you for joining. So this was the hierarchy. Now we are coming to a second feature of the MedDRA structure, that is its multi-axiality. And this allows for the representation of PTs in multiple SOCs based on medical considerations. Now, what is meant by that? Let's take the example of dyspnea, shortness of breath. If I would ask you in what SOC you would expect this to be in, some of you may say in SOC respiratory based on the manifestation side, but others may say in SOC cardiac disorders because dyspnea is an important symptom of cardiac disease. And both of you are right, and you will find PT dyspnea under both SOCs, one based on the manifestation side, but also based on the etiology of the condition. So this allows for data presentation and analysis based on different medical considerations, depending on your area of interest, and also depending on product-specific considerations. In order to achieve, again, standardization for cumulative data output of MedDRA-coded data, all PTs with multiple SOC linkages need to have a default or primary SOC assignment. So this primary SOC assignment will determine which SOC represents the multi-axial PT during cumulative data output and presentation for integrated safety summaries, periodic safety reporting, etc. The primary SOC is defined by MedDRA. This feature prevents double counting of events as respiratory or cardiac condition in our example of PT dyspnea. And the standardization that is achieved by primary SOC presentation of data is required by regulators as well and has to be followed. So deliberate changes, even if a database allows for it, will not be accepted. Usually, the primary SOC assignment is hard-coded in the coding systems, but if you have a system that allows you to choose, you must always select the primary SOC defined by MedDRA. Let's first look at the rules for the primary SOC assignment within MedDRA. If the respective PT has only one SOC linkage, obviously this system organ class is automatically its primary SOC. PTs for diseases and clinical signs and symptoms have their prime manifestation site as primary SOC. But there are three exceptions that you can see on the slide here. Firstly, congenital terms and hereditary conditions always have the SOC congenital as primary SOC. Secondly, neoplasms or neoplasm terms always have SOC neoplasms as primary SOC, with the exception of cysts and polyps, which have their prime manifestation site as primary SOC. And thirdly, infections and infestation terms always have SOC infections as primary SOC. Again, most PTs are grouped based on the manifestation site, with the exception of these three SOCs: congenital, neoplasms, infections, and infestations. Here an example using PT obesity cardiomyopathy. It has cardiac disorders as primary SOC, representing the site of manifestation, and a secondary linkage to SOC metabolism and nutrition disorders, representing the etiology of the condition. Please note that a PT can have any number of secondary linkages, not just one or two. Especially in SOC congenital, there are PTs that represent very complex congenital anomalies affecting multiple body sites. They may have up to 7 secondary SOC linkages, like for example the PT Charge syndrome. All these additional languages are called secondary. There are no tertiary or quaternary linkages. They are all equal. There is no ranking among them. So they are all called secondary linkages. And what is also important to remember is that multi-axiality starts at PT level, as you can see on the slide, not at the LLT level. Each LLT is only linked to one PT. Very important to remember. So hierarchies, we talked about hierarchy and the different levels of MedDRA. Here we are with the multi-axiality, and multi-axiality starts at PT level, not at LLT level. It can also start at HLT or HLGT level, but it will never an LLT will have secondary linkages. LLTs are only grouped under one PT. Another example, as already mentioned, many PTs are assigned a primary SOC based on the manifestation site, but there are these three exceptions that I've already mentioned: SOC congenital, SOC neoplasms, and SOC infections. And here we see an example for one of these three exceptions. PT influenza has SOC infections and infestations as primary SOC, and a secondary linkage to the site of manifestation that is SOC respiratory. Now, some PTs may contain information that relate to more than one of these exception SOCs. If so, the following prioritization applies. The congenital SOC has the first priority, neoplasms the second, and SOC infections and infestations has the third priority. So an example, PT congenital infection would have the primary SOC congenital and only a secondary linkage to infections and infestations. And a PT like infected neoplasm would have neoplasms as the primary SOC assignment and only, again, a secondary linkage to infections and infestations. In addition to these three exception SOCs regarding axiality and primary sock assignment, there are 3 single axial system organ classes excuse me, that you should be aware of. PTs in these 3 system organ classes only appear here and nowhere else. They are never multi-axial. And these are the 3 system organ classes: investigations, surgical and medical procedures, and social circumstances. You will not find any term that relates to lab results of hepatic parameters in SOC hepatobiliary. You will only find them in SOC investigations. And you won't find terms for hepatic surgery in SOC hepatobiliary. Again, they are only represented in SOC surgical and medical procedures. And a term like hearing aid user, you would only find in social circumstances, not in SOC ear disorders. Do we have any questions so far, Leander? Any questions regarding what
No,
we...
I've just asked for a clarification on one of the questions, Carol Ann. So if that comes in, then I'll let you know. And sadly, we've got a few of our audience experiencing a few technical problems and they can't see your presentation. But sadly, I think that might be their organisation's settings not accessing all of the features within Poll Everywhere, within
Oh, sorry to
GoTo.
hear that.
I'm very sorry for anyone that is experiencing problems with the not being able to see the slides, but we're not able to do any more to give you that access.
Yeah, we have tested everything, so it works fine. But of course, if your IT constellation in your organization is set up in a different way, then we cannot do anything about it. Sorry for that. Okay, then let's continue with the next poll questions. In which SOCs would you expect to find the PT ventricular arrhythmia? Do you think this is a multi-axial PT, or what would you think? Ventricular arrhythmia. Yeah, most of you got it right. It's of course site of manifestation. Think of the site of manifestation. This is of course ventricular arrhythmia. The site of manifestation is the heart, so you would find it in cardiac disorders. And we don't know what the etiology is. It could be anything. So that's why this PT is only it's single axial, so it has no secondary linkages. Next one. In which system organ classes would you expect to find PT allergic eczema? Think of the site of manifestation and the etiology. Allergic eczema. Site of manifestation, correct, is skin and subcutaneous tissue disorders. And what about the etiology? It's immune system disorders. Most of you got this right. Yes. Always think about the site of manifestation and the etiology of the condition. It's not an infection or infestation. We don't know that. It's just an allergic condition. So skin and subcutaneous tissue disorders would be the primary SOC, and the etiology would be represented by a secondary linkage to immune system disorder SOC. Well done. And now the next one. In which SOCs would you expect to find PT colon cancer? Think about the 3 exception SOCs. So where would you find this one? Neoplasms, exactly, would be the primary SOC. And the secondary linkage would be to the site of manifestation, that would be gastrointestinal disorders. Exactly. So it's not a congenital condition. It could be, but it's not specified as a congenital condition. So this would not be correct. And I think some of you have difficulties to find the correct box here to tip it or to click on it. So it would be neoplasm shock and gastrointestinal. These are the two correct questions.
Caroline, could I just ask a question just
Yeah,
on
yeah.
multi-axial? We had a question that why can an LLT not be multi-axial? Could you just explain a little more?
Oh, this would make the PT level is the medical concept level. So this really represents the medical condition. The LLT level is just contains quasi-synonyms of the PT name or colloquial terms, lexical variants, British, American English, etc. So this is rather for data entry purpose. So give guidance to coders to allow them to quickly find a suitable term for their given verbatim. So it doesn't make sense to have the multi-axiality on LLT level. It starts on the medical concept level because this is really the medical condition. And all the others on the LLT level, these are just representing the medical condition in a different wording. That's why it wouldn't make sense to have the multi-axiality already starting on LLT level. It's for data presentation, for data analysis purposes, we have this multi-axiality, and data analysis, data presentation always uses the PT level. So that's why multi-axiality was considered to start, or it was decided to start the multi-axiality on PT level. I hope this has answered your question.
Thank you, Caroline. And we had one more. How do you identify manifestation and etiology with respect to the SOC? Not sure if you're.
It's just medical consideration. So you really have to apply medical judgment when doing MedDRA coding because it's so granular. So you have to always understand what is the site of manifestation, like a skin disorder, for instance, and what is the reason for this condition, what caused it. So as in our example with the allergic eczema. So the eczema, of course, site of manifestation is clear, it's the skin. So this would be the primary SOC assignment in this instance. And the etiology, the reason for this eczema is the allergy. So it was caused by an allergy. So this is how you have to approach these structures. And you really have to have sound medical knowledge when doing MedDRA coding. In previous times, coding was often done by data managers. And when using MedDRA, sometimes you really need medical input in order to really code accurately and correctly interpret the given condition that is reported. Any further questions?
That's it for now. Thanks, Caroline. And we've had positive feedback on the explanations you've given. Thank you.
Thank you. Okay, so just to let you know, so this training, of course, will not be able to provide you with all the details of MedDRA structure and all related rules and definitions. To even better understand MedDRA, please refer to the MedDRA introductory guide, and I will show you later where to find it on the MedDRA website. In this document, you will find specific MedDRA rules and also conventions, as well as MedDRA naming conventions that are relevant to really better understand MedDRA classifications. As an example, per convention, the abdominal wall is considered a gastrointestinal structure, and the pharynx and diaphragm are considered respiratory structures. So I would really highly recommend to study this document thoroughly, the introductory part at least, so that your searches for suitable MedDRA codes are more focused and also more targeted. So especially if you're a beginner or less experienced MedDRA coder, MedDRA user, it is really helpful, and I'm sure that you will find it useful as well. Now let's start talking about coding conventions. So what are coding conventions? So generally speaking, coding conventions are written guidelines for coding with MedDRA in your organization. It is crucial to have them not only for your operational coding tasks, but also for inspection readiness, because inspectors ask for them, and you should have them available in writing to show that all medical coders in your organization are doing their job based on defined conventions. They may address topics like handling of misspellings, abbreviations, or handling of acronyms. Another area you may want to cover are combination terms and due-to combinations of medical concepts. There may also be terms that you would always like to query, like for example chest pain, to find out whether it is of cardiac origin or caused by other non-cardiac events, like for example pulmonary embolism. But you may also want to query reports of an unspecified infarction, necrosis, occlusion, etc., in order to find out the affected anatomical site, because you find these PTs in MedDRA: infarction, necrosis, occlusion, but these could really relate to very serious conditions, severe conditions. So you would really like to find out the affected anatomical site for these conditions. You may now ask yourself why such documents are needed at all. So first of all, coders may have a very different background, and they may need guidance how to handle very specific medical terms within MedDRA in order to achieve medically accurate coding output. Also, MedDRA is very large and nearly always provides a variety of coding options as compared to previous legacy terminologies. That is why coders need more guidance on how to prioritize and handle these options in order to achieve coding consistency, especially when they are working in different functions and geographical regions. And you may have the need for more specific coding rules for certain medical areas based on your product portfolio. It is often assumed that autocoders that look for a match between a verbatim and an LLT would solve all these problems. But this is of course not the case. Even with very sophisticated autocoding algorithms and lots of testing, autocoders will not cover all verbatim, so manual coding will still be needed. And clearly, autocoding results will have to be reviewed by qualified individuals with good medical background and sound MedDRA knowledge. Because not only human beings may assign wrong codes or code inconsistently, but also autocoders may run into problems when trying to interpret textual information that is relevant for coding. So in this first example here, it is reported that the patient was allergic to a CAT scan, and it was autocoded to allergy to cats. And in the second example, a myocardial infarction in the fall of 2000 is reported. And this verbatim was split and autocoded to myocardial infarction and fall. And these are really real-life examples nicely demonstrating that a QC of autocoding output is definitely needed. Any questions related to the coding conventions, Leander?
No, not at this time. Thanks, Caroline.
Okay. So then let's continue and look into an ICH guidance document for our topic today that is called MedDRA Term Selection Points to Consider document. With this document, you do not have to start with your in-house coding conventions from scratch, but can take the guidance in this document as the basis for your own coding rules. But whatever you decide to do and define in your coding conventions, your rules should be consistent with this document. Otherwise, you will run into problems during inspections or you may get feedback from regulatory authorities regarding your coding quality. If you have no need for in-house coding conventions, you may of course also use the PTC document as coding convention within your organization. Here's a snapshot of the front cover of the full PTC document. It is the latest version, released on March 1st this year, and provides term selection advice for industry and regulatory purposes. Of course, again, with the objective to promote accurate and consistent term selection to support common understanding of shared data so that we all speak with one language. And of course, it's recommended to be used as the basis for individual organizations' own coding conventions. This document was developed and is maintained by an international expert working group appointed by the ICH Management Committee, with members from regulators and industry of the ICH regions, the MSSO, and the Japanese Maintenance Organization, or JMO, and the WHO as an observer. There is one original and comprehensive version that is available in English, Japanese, Chinese, Korean, Spanish, and Russian, and this is updated with each major MedDRA version release, that means beginning of March each year. In addition, there are condensed versions of this original document in other MedDRA languages, except those that I have just mentioned, of course. And you see these languages listed on the slide: Arabic, Brazilian Portuguese, Czech, Dutch, French, German, Hungarian, Italian, Portuguese. These condensed versions focus on the general coding principles without going into further details for selected topics. They are not updated with each MedDRA release, but on an as-needed basis. You'll find the documents under the menu How to Use and submenu Support Documentation on the MedDRA website, and I will now show you where to find them. Let me switch screens here. Here's the MedDRA website, How to Use, Support Documentation. Let me click on it. Points to consider documents and MedDRA best practices document is on the top as a subheader, and here is the MedDRA term selection points to consider, the latest one. And you have it as a PDF, as a Word file where you can easily use to create your own conventions, and an HTML version that is easy to navigate. And in addition, there is one that is called redlined. The redlined version highlights the changes that were made in the document as compared to the previous version of the document. So if you are familiar already with this document, you can just refer to the redlined version and can easily find the changes that were made. Okay, and I've mentioned the introductory guide before. Here it is. So on the top, you see the latest MedDRA version. Here is the green header here. And there's a What's New document that summarizes the changes that were made in this version as compared to the previous version. And here is the introductory guide for MedDRA version 28.0. So here, this is what you can find on the MedDRA website. Now let me switch back. Here we are. And let's continue. So the PTC Points to Consider document provides comprehensive guidance and clear recommendations. But it is important to note that in some instances, it may provide more than one option to choose from. One of them will always be indicated as preferred option, but you are free to choose the alternative approach as well, if it is more suitable for your organization. But whatever you choose, document your approach in your coding conventions. Train your coders appropriately so that they are really consistent in their choice of option. In the appendix section 4, there was an update. So the versioning part now only refers the reader to the MedDRA best practices document, because there the versioning approaches, the different versioning approaches that you can choose from, is explained in much more detail. So that's why you only have the reference to this document there. The final decision on the versioning strategy is up to the respective MedDRA user. But when you have taken your decision, document your version approach and the corresponding processes, so that like the timing for the implementation of the new versions, what will be updated in pharmacovigilance, what will be updated and how it will be updated in clinical trials, all of that. So document your processes, document your decisions, not only for inspection readiness, but also for newcomers to your organization, so that everybody knows how to approach the versioning question. And the appendix also contains some useful links and references. Now let's look into some general coding principles that are addressed in the points to consider document. So quality of source data, how to perform quality assurance and why, do not alter MedDRA. We mentioned this already before. Always select a lowest level term, select only current lowest level terms. When to request a term, that one should use medical judgment when doing term selection, and to select terms for all reported information, to not add information, but not to subtract relevant information as well. And we will address them one by one in the next few slides. First topic is the relevance of good quality source data, the quality of data input. You all know what is meant by garbage in, garbage out. So the quality of your data input, of course, has a huge impact on the quality of your data output. So if you get poor data, unclear, ambiguous verbatims as a coder, always try to obtain clarification of data. It is also advisable to have an eye on CRF standards and design in clinical development. They must be carefully designed in order to provide clear data for coding purposes. So as an example, if you have tick boxes on your CRF that are to be mapped to MedDRA, these should not be associated with multiple MedDRA terms, because you wouldn't know how to code it, how to map this information to MedDRA. This means that MedDRA-related training is not only relevant for coders, but also for other functions in your organization, including investigators, to make sure that you get appropriate term specification for coding purposes. I've already stressed several times that your own organization's coding convention should be consistent with the points to consider document, and please be aware that this is definitely expected by regulators. It is inspection relevant. The document goes on with the topic quality assurance, and code assignments should, of course, be QC'd with an appropriate and systematic approach by experienced coders or physicians that are MedDRA experts, and this is also true for autocoder output, as we saw before. And just to let you know, also regulators perform coding quality control review of data submitted by different companies and provide feedback in case of relevant inconsistencies or relevant coding issues. So thinking now about data quality, you've got a reported term or verbatim of compression T4, T5. Would you code it, or would you seek clarification? What would you do? Compression T4, T5. Let's see. Most of you would seek clarification. Exactly. And I fully agree. I would also rather see clarification and would query this term. Now, why wouldn't we code this? Why can't we code the reported term compression T4, T5? We need clarification, yes. It's fully unclear. Why is it unclear? Too ambiguous and vague? Yeah, it should be more specific. This is why this term should be queried. The affected site is specified. It is the thoracic spine. But we don't know what exactly is compressed, whether it is the vertebra leading to a compression fracture, for instance, or an intervertebral disc that is compressed, or the spinal cord, or a nerve root. So this needs to be clarified, and that is why I wouldn't accept this term if I was a coder. Exactly. Thank you for joining. Now let's have another short exercise before addressing the next general term selection principle. Once you have selected an LLT that represents the verbatim, you choose the SOC that makes medical sense, or you follow the predetermined MedDRA hierarchy. What would you do? Let's see. Most of you got it right. You would follow the predetermined MedDRA hierarchy. Exactly. Let me close it. So why it is hardwired in MedDRA, and we said that MedDRA is all about standardization. So you should not make any ad hoc changes to the MedDRA hierarchy. You should really follow what is hardwired in MedDRA. So you would not choose the SOC that makes medical sense in your view, but you would follow the predetermined MedDRA hierarchy. Fully correct. We already talked about the principle to not alter MedDRA when addressing primary SOC assignment that is hardwired in MedDRA. So if you find that a term is inappropriately placed in the terminology, please do not change the MedDRA hierarchy, even if your database allows to do so, but instead submit a change request to the MSSO through the established change request process so that it can be reviewed and considered. So if you think that there should be another secondary linkage for a given PT and it's not there, do not do any alterations in the MedDRA hierarchy. If your database allows to do so, just submit a change request to the MSSO. Coding is done on LLT level. We said this. That's the data entry level. We also, so we discussed this before, and only current LLTs must be used in ongoing coding. Of course, we should not use the non-current terms when doing ongoing coding. The selected LLT should capture as much information provided by the original verbatim as possible. So as can be seen in this example, reported is an abscess on the face. This verbatim should not be coded to just abscess, because it is medically relevant to also capture the manifestation site. So we would select LLT facial abscess in order to capture as much information from the report as we can. And always remember to select current LLTs only. The non-current LLTs are still in the terminology for historical purposes to support interpretation of legacy data and legacy data conversion, but they should not be used for ongoing coding. Besides the previous example with the reported abscess on face, here another example where you may struggle with MedDRA specificity. How would you code red skin on soles of feet? You see that there are plenty of somehow suitable LLTs to choose from. Skin red, erythema of extremities, plantar erythema, redness of legs, localized erythema. red skin on soles of feet. What would you do with this one? How would you handle that? What do you think is the best LLT to choose to match the reported verbatim? So let's see. Plantar erythema is the favorite solution, and you're fully right. All the others are also capturing the underlying condition. But plantar, here we have the medical term for soles of feet. Plantar is, of course, the most specific term that we can find, exactly capturing the manifestation side of the redness of the skin and replacing the red skin by erythema. So both the soles of feet and the red skin are to be phrased in a different way in medical language, and then you have the plantar erythema that is perfectly capturing, fully capturing what has been reported here. So well done, thank you. Plantar erythema. If you can't find a suitable MedDRA term that adequately represents the medical condition to be coded, so don't solve it with workarounds, but use medical judgment. As an example, at the start of the COVID-19 pandemic, when receiving a report of an event related to COVID-19 infection, one wouldn't have found an exact term for it in MedDRA. But when using medical judgment, you would have found terms like coronavirus infection, not as specific, but capturing the medical concept on a more general level. So this term was to be selected as a placeholder before the COVID-19 terms were added to MedDRA. So avoid workarounds, look for a more general term, look for terms with a slightly different wording, as we saw with the plantar erythema. That represents the concept. Use online references and medical textbooks like the Dorlands, the professional version of the MSD manual that is available for free on the internet, Access Medicine, websites of well-known university hospitals, etc., to check for synonyms in medical terminology, because these may already be represented in MedDRA. But if, despite all these efforts, you finally cannot find a suitable term, then submit a change request to the MSSO. So as mentioned before, medical knowledge is more relevant for coding than in previous times when coding was in the hands of data managers. MedDRA really requires sound medical knowledge and quite frequently also the input of physicians to achieve medically accurate coding output. Any questions,
Yes,
Leander?
yes, there are, Carol Ann. Thank you very much. We've had a question back on multi-axiality, but if I follow the hierarchy for a multi-axial term, how can I be sure to end on the right SOC?
So the multi-axiality is predefined by MedDRA, so it is always correct. And usually in the coding systems, this is the hierarchy as defined by MedDRA is integrated in the coding systems. So in most of the coding systems, you do not have any option to choose your own system organ class, so to say. So it is given by MedDRA itself. You don't have to make any choice. It is only when your coding system does not support the full MedDRA hierarchy as it is provided by MedDRA itself, then it is difficult. But as a coder, this is then the task of IT personnel. You as a coder would select the best term that you can find in MedDRA in order to represent the reported condition. And then MedDRA itself, and if your data or an IT colleague of your organization in your organization would add the MedDRA hierarchy to this LLT that you have selected. And
Thanks, Carol Ann.
Yeah,
We had one more, and
yeah,
I'm not sure if this is too specific, but I'll read it and then you can guide us
yeah.
all. In patients treated with, and excuse my pronunciation, but manidipine peritoneal cloudy effluent, in brackets PT, may
Hmm.
occur in the case of peritoneal dialysis. This PT has two SOCs, where the primary SOC is gastrointestinal disorder, but patients not on dialysis do not have this ADR. Shouldn't the SOC injury, poisoning, and procedural complications be selected?
But the injury sock is it's always a problem. But I think um, based on the MedDRA philosophy for classification, you would first really select the primary SOC for the manifestation site, peritoneal fluid, so meaning gastrointestinal SOC. And then the etiology, that it is an injury, it is a procedural complication, is added with a secondary linkage. It's um, it's sometimes difficult to understand, but I think it's logic when you consider the MedDRA philosophy and the rules that are behind. So first of all, manifestation site, and then the etiology, that is um, procedural injury, as you correctly mentioned.
Thanks, Caroline. That's it for now. Thank you.
Okay. So then let's continue. Remember, we are still with the basic principles for meta term selection. When coding, do not omit medically relevant information. In other words, make sure to capture and appropriately classify all reported events. So we are not interested in causality at all because it is captured in a separate database field elsewhere, but we should capture all reports of device-related events, product quality issues, medication errors, medical and social history of patients, investigations, indications for use as appropriate. So all of these terms, and you saw it in the graph with the blue circle, all these terms are included in MedDRA. As mentioned in the previous slide, we should cover as much of the medically relevant information of the reported verbatim as possible. And we saw that in the previous example describing a facial abscess. But on the other hand, we should not add any information. So in this example, no diagnosis pancreatitis should be made out of the signs and symptoms shown: abdominal pain, increased serum amylase, and increased serum lipase. So this would be split and coded to abdominal pain, serum amylase increased, lipase increased. And it would not be appropriate to assign an LLT for the diagnosis of pancreatitis. So in other words, as coders, we should code as reported without adding or omitting medically relevant information. That's really the basic rule: code as reported. Do not interpret and make a diagnosis out of this information. This is not our job as coders, but should take place when it comes to data retrieval and analysis, where one would look for clusters of findings indicating specific diagnosis. As coders, we would split such a report and code all these findings separately. After these more general coding principles discussed in the first part of the PTC document, the second part then addresses some specific coding topics, individual types of data, and how to handle them in operational coding. You see them here: diagnosis and provisional diagnosis with or without signs and symptoms, death and other patient outcomes like hospitalization, for instance, suicide and self-harm, combination terms, prioritization of age versus event specificity, prioritization of body site versus event specificity, congenital terms, neoplasms, investigations, and it continues on the next page here: medication errors, accidental exposures and occupational exposures, misuse, abuse, addiction, social circumstances, off-label use, product quality issues. So a long list of specific topics. So if you are not familiar with the document yet, I can only really highly recommend to read the document to make yourself familiar with the content so that you know where to find the guidance for these coding scenarios. You don't have to know it by heart, of course, but you need to know where to find guidance for the different coding scenarios. And of course, you should be very much familiar with the content if you are responsible for your own in-house coding conventions in order to make sure that your conventions do not contradict the rules and the guidance provided in the PTC document. Any questions for the last part that I presented, Leander?
No, we had a question about how often the PTC is updated and the rationale behind it. I did answer it, but I don't know if you want to.
Yeah, so the full document is released every year with a major release of MedDRA 1st of March. And the condensed versions, I mentioned that these only refer to the general principles, and these general principles do not change much, and that's why they are only updated on an as needed basis, so not really frequently.
Thanks, Caroline. No other questions.
Mhm. Now, in order to efficiently and effectively search for suitable MedDRA terms for a given verbatim, it is not only relevant to understand MedDRA structure and the rules behind and the details of the PTC document for MedDRA term selection and your own in-house coding conventions. But it is also crucial to make yourself familiar with the MSSO MedDRA browsing tools or your own browsing tools if you have them in your organization. The MedDRA browsing tools provided by the MSSO are free to use by all MedDRA license holders, and I will introduce some of their functionalities that are relevant for operational coding in the next 2 slides. So the MedDRA browsers are used to browse the terminology in order to find suitable terms for coding or suitable standardized MedDRA queries for data retrieval purposes. Out of the 3 MedDRA browsers that are provided by the MSSO, one is intended to be installed on local computers and 2 are accessible via the internet. So this is the one that is installed on your computer, the MedDRA desktop browser. You can download it together with the release files from the MedDRA website. And here we have the web-based browser and the mobile MedDRA browser. So the mobile version for smartphones and tablet computers and a version for use with laptop or desktop computers. You can see 2 URLs on the slide, one for a new web-based browser, here it is, and one for the legacy web-based browser, here it is. Both are currently available as we are still in a transition period, but towards the end of the year, the legacy web-based browser will be switched off. I will use the legacy browser in today's webinar because you may already be used to it. But if you would like to make yourself familiar with the new one, please refer to a recorded session where the look and feel of the new browser is demonstrated on our YouTube channel. I will show you later how to find this YouTube channel. The new browser provides all functionalities, just to let you know, of the legacy one, but the user interface looks different. That's the only change that was made. So no, you don't have to be afraid that some of the functionalities have been lost. So that's not the case. So I will use the new web-based browser in the next advanced coding webinar. So if you would like to hear more about it, you can join the advanced coding webinar or refer to the YouTube channel where we have 2 recorded sessions that really focus on the demonstration of this new version of the web-based browser. So that's about the browsers. So all these browsers, all of them, require MedDRA ID and a password in order to access them. They support the view and search of MedDRA and the SMQs. They support all MedDRA languages, including a language-specific interface. And the desktop browser and the web-based browser have the ability to export search results and research bin to local file systems. So that's mainly relevant for data retrieval if you want to compile your own data retrieval, your own queries for data retrieval. There are some features of the browsers that mainly relate to data retrieval, like the research bin function, for instance. And I have highlighted those that are useful for coders in red lettering on this slide here. So for coding purposes, the view of the primary and secondary link information and the advanced search options are very helpful to make your searches more focused and efficient. If you're considering the submission of a change request to the MSSO and would like to see whether another MedDRA user has already submitted such a request, then the supplemental view of the browser is really useful. Please note that this feature is not available in the desktop browser because otherwise in the desktop browser you would really have to upload the supplemental terms on a regular basis. So that's nearly impossible. It's only available in the online tools that and the MSSO is taking care of the fact that all accepted change requests are really incorporated in this supplemental view. I will demonstrate these functionalities in a minute. Now let me switch screens in order to give you a short introduction into the basic functionalities of the MedDRA web-based browser. So let me go here and switch screens. Here we are. So here is the shortcut to the web-based browser. I will access it with my own MedDRA ID and my credentials and say login. Here we are. And here we have the user interface. So as already mentioned, the browser is designed to review the MedDRA hierarchy at first and the SMQs. So you see here is the SOC view. We will use this view today because we are talking about coding, but you could also choose the SMQ view, standardized MedDRA queries, if you are working in the area of data retrieval and analysis. So you can perform searches for coding and analysis tasks in English and the available MedDRA translations. So here you can see all the translations that we have available so far, and you can compare up to 3 languages. Let me select Czech, for instance, and you see immediately that here the system organ classes are not only provided in English but also in Czech language. So we will keep it with English. On the top we have configuration options. Here I've selected English for my interface, but you could also select your own language if you prefer. Then we have the legends, very important to be familiar with the legends. If a PT has a blue circle around it, it's a multi-axial term that you are looking at in its primary SOC. Green circle, again a multi-axial term that you're looking at in its secondary SOC. Red square around a PT identifies an uniaxial primary term. Blue circle, the primary system organ class for a given term. And here, red lettering, red circle around an LLT identifies non-current LLT terms. Very important to remember. Then we have a direct link to the MedDRA documentation, to the points to consider documents, to the introductory guide, brings you directly to the homepage, MedDRA homepage, and here a link to a very detailed user guide to make yourself familiar with the tool. And these are only relevant for retrieval purposes. Language we already mentioned. You can select any version that you would like to look at. Since the release of the first official MedDRA version that was released, the 2.1 release, we have selected the SOC view because we are talking about coding today, and the released version of MedDRA, so the official released version 28.0. You could now say, I would always like to see the codes of certain terms, and you would immediately see the codes here in the SOC for the SOCs, but it makes the screen quite busy, so I rather disable it. And you could also show the non-current terms. So let's keep this enabled. So on the left, you see the so-called Explore window. Here you see all the SOCs, and when clicking on the plus sign, you can really explore the full hierarchy. You see the HLGTs now. You can open one HLGT. You see the HLT here. Then you see all the PTs, and now the color coding comes into play. You see the acquired complement deficiency disease has a green circle around it, so it's a multi-axial term, but you are looking at it in its secondary SOC. Bone marrow hemorrhage has a blue circle, so again multi-axial, but it has blood and lymphatic system disorders as its primary SOC, and the red circle around it identifies the single axial PTs. So this way you can do the so-called top-down searches here down to the LLT level. Here we have the LLTs. All of them, you can explore the full hierarchy of all system organ classes down to LLT level. So let's assume that we have a report of an insufficient cardiac function. Let me collapse this all again. Collapse all. Insufficient cardiac function. We would look, of course, into the cardiac disorder SOC. This is where we would look for it. And here we have the HLGTs, and heart failures would, of course, be the HLGT we are interested in. Heart failure signs and symptoms, no, this is not what has been reported. It was not specified as left or right ventricular failure, so we would look into the HLT heart failures not elsewhere classified. Lots of them here. And what do we have here? Cardiac failure. So that would be the best approximation to our insufficient cardiac function. And then we would look for an LLT that is closest to the wording of our verbatim. Insufficiency cardiac. That would be the LLT that is closest to our insufficient cardiac function. This is how you would do your top-down search. And you see here are two non-current LLTs. One has a typo in it. Hydropic decompensation is a vague term, ambiguous term, could be any decompensation, must not be cardiac, so that's why it was set non-current. In addition to the top-down search, we have another option of performing our search, that is the bottom-up search. So in order to do a bottom-up search, we would enter the reported term into the search window that you find in the center here of your interface. So let's do that using the strings kidney, and also the word stem insufficient. to capture insufficiency and insufficient, and click search. So we have several proposals here. Acute renal, so it's we don't know whether it was acute or chronic. We have several adrenal because it contains renal, adrenal insufficiency terms in there. Insufficiency renal, we see that there is no insufficiency of kidney. So we see that the tool itself has replaced kidney by renal, and this is due to the synonym list that is behind the searches. So the tool automatically replaces some terms: cardiac with heart, kidney with renal, liver with hepatic. So very useful to enable that. Ignore diacritical marks, show PT LLT with categories. All these functions are very useful to display your search results. So we have insufficiency renal and renal insufficiency. This is renal insufficiency would be the best approach to our verbatim. It could be that your list is much longer, so you would like to really streamline the search results, and then the advanced search option comes into play. So we have the kidney insufficiency, and we could say does not contain, so our search results should not contain adrenal. And then click search. And then you would get only proposals that relate to renal conditions. So the adrenal have now disappeared, and the proposals are, the list is much leaner. So renal insufficiency, insufficiency renal, these would be the correct assignments. If you do a right mouse click on the term, you can say go to browser, and you would see the LLT in its hierarchy. So you see that the PT is renal failure of insufficiency renal, and you can look at the siblings and at the neighbors, and you see that we have a post-renal failure, pre-renal failure, renal failure neonatal. So if your verbatim would contain more information than just kidney insufficiency, you would be able to look at the neighbors and maybe even find a more specific term for the reported condition. What you could also do is to say open history. You would, it takes a while because it will show you the whole history of the term. You see that renal insufficiency renal was already included in the version 2.1 of the terminology. It had a renal impairment NOS as a PT, but then based on naming conventions, the NOS terms are only available on LLT level anymore. So now the PT reads renal insufficiency, and in version 7.1 it was replaced by renal failure. So you can immediately see what type of changes were made in the hierarchy for this given LLT. You could also say copy the term to paste it in a document, copy the code, and you can print it. Open details and occurrences. So if I click on the term, you see that on the right-hand side, you see the term details in English. Here we have the MedDRA code and the MedDRA term, and you can also see the SMQs that contain this respective PT renal failure. So quite a lot. And you see the hierarchy. So this is a single axial PT renal failure. It's only grouped under one system organ class. And here again, the SMQs that it is included in. So what we could also do, important to know, is let's go back to the basic search. You may be interested in renal function investigational terms only. So if you would look for renal function, and then you would get a long list that contains diagnosis, not only investigational terms. So then you could really select one system organ class, here investigations, in order to again streamline your search. You would only like to see investigational terms that relate to renal function. And if you search then, you would get renal function test, for instance. You could do again a right mouse click, say go to browser. Investigations is a single axial SOC, so never multi-axial. And you see that there's a number of terms in renal and urinary tract investigations and urinalysis. So the renal function analysis, long list here, and among those also the renal function test abnormal and normal. So this helps sometimes to clearly better guide you to the specific area of interest that you have. Now, last but not least, the supplemental view. So let's assume, so I clear my selection again. Let's assume that I have a report on a hormone receptor and HER2 positive breast cancer. And I search for it. So what I find is a hormone receptor negative HER2 positive breast cancer, or a hormone receptor positive but HER2 negative breast cancer. So no hit for a breast cancer that is positive for these two aspects. Now I could, of course, consider change request, but what I can do in order to see whether maybe such a change request was already submitted and maybe accepted by the MSSO already, I could look into the supplemental view, and you see that the screen changes color in order to make you aware that this is not the officially released MedDRA version, but the one that will be released with the next MedDRA version release. So it's showing all the supplemental terms. So those change requests that were accepted already, the supplemental terms. So I will enter the same information again. Hormone receptor, HER2 and breast. And here we have the hormone receptor positive, HER2 positive breast cancer, surrounded by a green dotted line. So this identifies the supplemental terms. You see it's a PT on its own. We could also right mouse click, go to the browser. You would then see it in its hierarchy. Here it is. So this would save you some time. You see it's already there. It will be released with the next MedDRA version, and you would now not submit a related change request. So with this, are there any questions, Leander?
Just one question, Caroline. What does uniaxial PT mean? Does it mean that PT does not have multiple SOCs, only one option?
Yeah, exactly. Single axial, uniaxial means that a PT only has one system organ class linkage.
Thank you. And is it possible to use it when coding, is the final part of that question?
It will always be the one that you would choose, because that's the only linkage that is provided by MedDRA. So as I said, all of this is hardwired in MedDRA. So it's a primary SOC, and this is the only SOC that is available for the respective term. So if I click on this hormone receptor positive, you see it has two linkages. One, because this is one of the exception SOCs, the primary SOC is neoplasms, and the second represents the manifestation site reproductive. And this is hardwired in MedDRA. So don't be confused. Most of the coding systems really use in the coding systems, the whole MedDRA hierarchy is implemented, so there is no way to choose any system organ class. I only mentioned it because there may still be some coding systems where system organ class can be chosen, and then you should really look into MedDRA and select the one that is like here in the browser, and select the primary SOC that is indicated in MedDRA.
Thanks, Caroline. And the next question I think is too specific, but if you can guide me on this one. What is the code for floaters in right eye grade 1, where they specify grade 1? I
Oh,
think that's
it's too much for today.
Yeah.
So we are with the coding basics, and I'm running out of time actually. So I have to speed up a bit in order to really cover what our exercises and the demonstrations. Okay.
Yes, thank you very much, Caroline. Thank you.
So let me switch back to my slides then. So, and now as the first, at first, some tips and hints that you should be aware of. So when assessing information for coding purposes, you should not directly access the MedDRA browser, but really first look at the reported term, the verbatim. And you should check whether it's a clinical condition, a diagnosis, clinical sign or symptoms, whether it's an indication for use, a test result, investigational result, an injury term, whether a procedure is reported, a medication error or product use issue, whether a product quality issue is reported, just a social circumstance of the patient, a device issue or procedural complication, or a combination of these. Because the type of report will influence your search for suitable MedDRA terms, of course. If reported by healthcare professionals and in medical language, your search can be more focused and finding a suitable MedDRA term will be straightforward in most instances. But if it is a consumer report in pharmacovigilance, the verbatim may be vague and not as easy to classify. So if something is reported vaguely, don't try to make more sense out of it. Remember the fundamental MedDRA coding rule, code as reported, and do not add or subtract information when coding. So break the information down to find out what was actually reported, and this will help you to find the best way to find a suitable term in the browser. And as I've shown when searching in the browser, use word stems like intestine to cover both the wording intestine and intestinal. If your wording is too specific and too narrow, you will miss suitable terms otherwise. Also consider synonyms, as we saw with the plantar erythema when searching for a condition affecting the leg, like lower limb or lower extremity, and tick Use Synonym List feature in the browser to further support your search, where the tool itself replaces words like, as I've shown you, kidney with renal. And if you find some more suitable term, look at the neighbors. There may be even better, more specific terms for your verbatim. And if not successful, browse the MedDRA hierarchy with top-down and bottom-up approaches to find the best approximation to your reported event. So again here, the QR code, just in case you have lost it in between. And here's the first coding example. It is reported that a patient suffered an allergic reaction to an antibiotic. So when I switch to the browser and switch to the release version again, and I enter allergic reaction and search, I get a direct hit. If I go to the browser, then I see it in the hierarchy, and I see its allergic reaction is grouped under the PT hypersensitivity in an HLT called allergic conditions NEC. And if I look into this HLT, I see that there is an HLT, allergies to foods, food additives, drugs, and other chemicals. So I'm in the wrong HLT here when only searching for allergic reaction. If I would search for allergy and antibiotic, then I see allergic reaction to antibiotic. So here we are, go to browser, and there we find the allergic reaction to antibiotics, and it's grouped under PT hypersensitivity, drug hypersensitivity in a separate HLT. So always, it is always helpful to check the hierarchy to reassure yourself that you are on the right track when selecting a term. Let us continue. So here, in the second example, the patient states that she is experiencing cold sweats. So here I've prepared a quiz question for you. So what would you search for? What would you type into the browser, into the search field? The patient states she has been experiencing cold sweats. Sweat, yes. But here we have specific cold sweat. Exactly, sweat. Cold sweats. Okay, thank you for joining. So let us look into the browser again. If I would enter cold sweats, oops, I'm not good in typing, sorry for that, and search, I wouldn't find nothing, because MedDRA is a singular terminology and referring to single events. So always use the singular when searching, and then you would have immediately a direct hit, cold sweat. Here it is, go to browser, you can see it in the full hierarchy here, cold sweat, same PT, and some synonyms are under this PT like clamminess, clammy, skin cold, clammy. So most of you got it right because you have already suggested to just use the singular term. Sweat alone would provide you with quite a number of hits, 59 here. So your search should be more specific in order to streamline your search results. Next one. In the next example, two abnormal lab results are reported, an increased troponin and increased CPK-MB. So this information should not be combined by selecting LLT cardiac enzymes increased only. Remember, always code as specifically as possible, so split this verbatim and code each finding individually. So let me again show you in the browser. Troponin increased. Here we are. Troponin increased would be the correct term here, easy to find. And CPK-MB, let us check whether this is available, whether this is an unambiguous abbreviation. Yes, and it is. Here we have CPK-MB increased because CPK-MB is considered an unambiguous abbreviation. And of course, the PT then really specifies blood creatine phosphokinase MB increased. Next one. We have a reported medication error here. The patient took the wrong drug by mistake and experienced shortness of breath after intake. Again, we have two separate events. So let's search again in the browser. Let's first search for incorrect drug. incorrect patient, incorrect drug administration rate, duration, storage, nothing. Incorrect. Incorrect. Let's use a synonym for incorrect, like wrong. And we have a direct hit here, wrong drug. But in our instance, we were told that the wrong drug was actually taken. So wrong drug would be too unspecific. So we would have to look for a term, wrong drug administered. Here it is. So exactly representing what has been reported in our instance. Wrong product administered would be the PT. And then the the patient experienced shortness of breath, and shortness of breath is again a direct hit in MedDRA. Breath shortness, shortness of breath, here we are. So easy PT would be dyspnea. So so the consequence of the medication error is to be coded to shortness of breath. Go back to my slides. And here we have a 2-day-old baby that has a mild fever, and you hear that it's really suffering from the mild fever. So what would you do with this one? Your turn again. What would you search for? What would you enter in the browser? Fever, exactly. Do we have some more information? Neonatal fever, yes, perfect. So we have demographic information in this instance. So let me again switch to the browser. If I just enter fever, you see that we have 191 search results. Of course, an exact match as well, but then we have lots of different fever terms. So we know that it was a baby. If I enter baby, there's nothing. I could say newborn, was 2 years old, and then again the synonym list comes into play. It replaces newborn with neonate, and here we have fever neonatal. Exactly, that would be the best term that we can select, because it does not only represent the underlying condition, the fever, but also captures the demographic information that it was a 2-day-old child, a baby. Next one. This now does not describe an adverse event. What is it that has been reported here? A 35-year-old woman was taking drug X to prevent relapses of multiple sclerosis. It is an indication for use of a drug, that is the prevention of the relapses of multiple sclerosis. So let us check in the browser again and enter prevent and multiple sclerosis. Nothing. Even if I correct my typo here, nothing. So again, we have to think about a synonym for prevention, and this would be the medical term prophylaxis. And here we have the multiple sclerosis relapse prophylaxis, an exact match to what has been reported in our verbatim. Multiple sclerosis relapse prophylaxis. Again, we had to replace the reported information by a medical term in order to find a suitable term for this indication for use. Next, it is reported that the patient had a pathologic fracture of the neck of the left femur. Remember the basic MedDRA rule: code as reported and capture all relevant information. So here a specific etiology of a fracture is reported. It is not a traumatic, but a pathological fracture. And we have the affected site, that is the neck of the left femur. So let me again switch to the browser and just enter pathologic fracture femur in search. And here we have, of course, a pathologic fracture of femur, but we have even a more specific term, pathologic fracture of neck of femur. Here it is. And it's grouped under pathologic fracture. You see when we go to the browser, here is the hierarchy of this PT. And of course, it is not just a traumatic fracture, it's a pathological fracture, and often it is caused by an underlying disorder like neoplastic disease, and that's why it's has a secondary linkage to oncologic complications here, to neoplasm shock. So, and of course, a fracture always represents an injury. That's why it has a secondary linkage to injury shock as well. Now let me switch back. Next, it is reported that after a procedure, a patient experienced constipation. So what would you do with this one? What would you enter to capture the condition and the timely relationship to a procedure? Post-op, yes. Post-procedure, complication, constipation. It would always be better, instead of procedure, to just enter proceed in order to capture procedural and procedure. Post-procedure constipation. So thank you for joining. Let me switch to the browser again. We have the constipation. And we have the information that it was after a procedure. And here we have the post-procedural constipation. If we go to the browser again, you see it's under post-procedural constipation. It's in the injury shock and has secondary linkage to gastrointestinal disorders. Let me switch back. Here we have a report on a fatal case where a 66-year-old man suffered a ruptured aortic aneurysm. So based on the PTC guidance, this is the first thing to remember. Based on this guidance, death is an outcome and should not be coded when a reason for the death is provided. So here we know, because the fatal event, the fatal outcome is captured elsewhere in the database. So if we have a reason for the death or for a hospitalization, then we would only code the event that led to the death of the patient. So here we have the ruptured aortic aneurysm. So I will refrain from switching to the browser because it's easy going if you enter aort, aneurysm, and rupt in order to capture or cover both rupture and ruptured. Then you would easily find the LLT aortic aneurysm rupture, and it has the same PT and is grouped in SOC vascular, of course, primary SOC. Next one. Quite frequently, product quality issues are reported with or without sequela. Here it is reported that the product was a counterfeit, and when entering counterfeit in the browser, we get two options, suspected counterfeit product and product counterfeit. So here we know it's a product counterfeit, and that's why this would be the correct code assignment here, LLT product counterfeit. This was again an easy one. Here we have, we're talking now about social circumstances. Here it was reported that the patient was confined to a wheelchair. Now your turn again. What would you look for? Patient was confined to a wheelchair. Invalid. Wheel. Anything else? So let's try in the browser. If I enter wheel as suggested, then I always find the direct match wheelchair user here. Wheelchair user, of course, when I click on it, you see it. It's grouped under disability issues, HLT, and it's grouped in social circumstances. So it's a single axial SOC. We talked about that. So if such an event would be reported as an adverse event and not in medical history, one would of course ask for more information why this patient was confined to a wheelchair. But if no further information can be obtained, then LLT wheelchair user would adequately capture what has been reported. And here, next one, the pharmacist made a mistake in compounding the medication. So again, compounding, let me enter just compounding. Product compounding error. Here it is. Product preparation error is the PT. Note that if I would have entered drug compounding, we would have no suggestions from the browser. So here, if you don't find something for drug, always replace drug by product, and then you will find product compounding error. Here it is. And again, let me go back. And last but not least, here you're looking at a case narrative, as one would see in drug safety reports. Previously, we had individual verbatims, and here we have to perform term extraction and then code the highlighted medical information one by one. So what do we have here? First, we have the indication for use of drug X, that is rheumatoid arthritis. Then the patient has history of colon cancer and cigarette smoking, 2 additional codes. He has now developed an aortic valve stenosis and underwent aortic valve replacement, 2 additional codes for the condition and subsequent surgery. And after the surgery, he suffered a sternal wound infection. This would be the last event that needs to be extracted and coded. All these different types of information can be coded with MedDRA: the indication for use, the medical history data, the adverse event, and the subsequent surgical procedure followed by a post-operative complication. Now, it's only a few minutes left. Just try to code some verbatims. Here is the username and password, just in case you do not have your own browser. Let's try if you can make it. It's just 5 of them. Here again, the QR code, just in case you have lost connection. And here's the first one to search for you. She was diagnosed with pneumonia caused by COVID-19 infection. So we have a pneumonia. It was caused by COVID-19 infection. Anybody has a suggestion for it? Yes, exactly. COVID-19 pneumonia, there is a perfect term. COVID-19 alone would not suffice because we know that the COVID-19 infection is a pneumonia. So it could be, yes, pneumonia. We know the infectious agent. So COVID pneumonia, yes, you would enter this as search string. Perfectly done. COVID-19 pneumonia, that's the correct assignment. Next one. Woman ingested her husband's blood pressure drug by mistake. What would you do with this one? This one is tricky. Is it a medication error, an administration error, or is it something different? Accidental exposure to drug. Well done. It's not off-label. Off-label use is defined differently. It's not a medication error. It's an accidental exposure. Let me show you. Accidental ingestion of drug would be the correct assignment, and let me show you shortly in injuries, poisoning, procedural complications, we have the medication errors and other product use errors and issues. And you see that the accidental exposures to product are separate from medication errors and issues. So here you find the accidental device ingestion by child, accidental exposure to product with really more specific LLTs like the accidental ingestion of drug. So these terms, accidental exposures, are to be assigned when the drug that is taken is not the one, the woman was not supposed to take a drug. It was not her drug something went wrong with. It was the drug of her husband. So it was really an accidental exposure. So most of you, or some of you, got it right. So well done. Be aware that accidental exposures are different from medication errors and product use errors and issues. If you want to hear more about it, there is a separate webinar about medication errors and how to classify these terms. Next one, the patient developed hyponatremia while hospitalized. Again, quite straightforward. So we have an underlying condition, hyponatremia, and we know it was during hospitalization of the patient. Iatrogen could be also nosocomial whatsoever. Hyponatremia, yes, you would look for hyponatremia and hospitalization, exactly. So the correct code assignment here would be hospital-acquired hyponatremia. There are many hospital-acquired or nosocomial terms in MedDRA. You will find those. In this instance, the LLT is just linked to hyponatremia, but you can really code the reported information very specifically by this LLT, hospital-acquired hyponatremia. Nurse noticed that the injection solution had an unusual odor. What to do with this one? What are we looking at? It's a product quality issues. Product odor, yes. It's a product, yeah, that's the product quality issue, but we have a specific description of this product quality issue. Product odor, yeah, the product odor was abnormal. So here it is, product odor abnormal. You will find it in product issues system organ class. So it's a product quality issue that the product odor is abnormal. And the last one, I'm sorry for exceeding our time today, but it's really hard to calculate because of the questions that we get. So here, elderly woman complained her arm was tender where she has received her seasonal flu vaccine. So it was tender where she had received her seasonal flu vaccine. So it's a administration site reaction that is specified because we know that she has received her seasonal flu vaccine there. Tender injection, application site. Application site you would rather use for topical administration of drugs. Vaccination site tenderness. Exactly. That's the best term that we can find in MedDRA. We know it's a vaccine, so the correct assignment here is vaccination site tenderness. And for this, I will shortly look into the general SOC here and just show you that administration site reactions here. You see we have the administration site reactions, application for topical application of drugs, implant, catheter site reactions, infusion, injection, instillation, and here a separate one for vaccination site reactions. So quite a number, and it's really important to differentiate between these reactions depending on the route of administration and what type of medication, of a medicinal product is administered. So let me switch back, and we are nearly done. This is what we have addressed today. And are there any further questions, Leander? I'm sorry, I was quite fast now in order to really cover everything in our webinar, but did we get questions, further questions?
Yes, we do have questions. And if we run out of time, I have mentioned that you might take some of them offline and answer them afterwards,
Yeah.
if that's better. But we had one in relation to the example that you mentioned, the hormone receptor HER2 breast cancer.
Yeah.
So if you would have a report of the hormone receptor HER2 breast cancer, you would have to query it in order to find the correct LLT. Is that correct?
No, but because if you would look into MedDRA, you would see that there's also one. So there's different combinations of. You would also have a breast cancer term, or one that is only hormone receptor negative or positive, or you would have the HER2 positive and negative breast cancer as separate PTs, and the combination. So all of them are available. You don't have to query. You always have some, so to say, more general terms, not only the most specific. If you don't have a specific, if you only have specific terms and you cannot find a more general term, then of course you would submit a change request. But not, for the breast cancer terms, I can say that you find all different combinations and also the more general term breast cancer, female. Any more?
Yes, Caroline, there are some more questions, but I'm conscious of the time, so I'm not sure if
Yes,
you want to
yes.
answer them now
So
or offline.
I can take them offline just to give you some more hints to useful information, coming webinars. So if you didn't attend yet, what is MedDRA and how is it used? It provides you again with some basics of MedDRA. Here are the webinars that we offer in June. Here is our webinar today. There are others. You see that we also provide these webinars in Chinese and French, for instance. Another one will be provided in Central European Time in June. Here the advanced MedDRA coding webinars. Then we have for advanced coders the Let's Code Together webinar. This is in workshop format, and where the verbatims that are discussed there are provided to the registrants in advance so that they can prepare for the discussion of these verbatims. And as I've mentioned already that there are separate webinars for the MedDRA coding of medication errors. You see it's provided in Spanish and here in English. We also have webinars in Brazilian, Portuguese, and in Russian. And here what I just wanted to show you is the YouTube channel. Last but not least, if I go to the MedDRA website again and click on Contact, then you see here the icon for the YouTube channel. If I click on it, then you see all the trainers here. And if you click on, for instance, what can we do here? The Chinese would not be. Here we have my colleague Jane. So here, if you click on the playlist, you see all the recorded sessions. Getting started with MedDRA, MedDRA coding basics, advanced MedDRA coding, data analysis, standardized MedDRA queries. And here, by the way, is the MSSO MedDRA tools demonstration, the new web-based browser. So here, if you're interested in the new web-based browser, you find the demonstration here. So with this, we are really done. So sorry for exceeding our time today, but really I hope that you found this webinar useful, and I hope to meet you again in one of the trainings that we offer on a regular basis, as we saw in our schedule in the screenshots that I've provided to you. With this, I would like to thank you for your interest in today's topic and for your active participation. The many questions that we got. So the ones that I couldn't answer based on time constraints, I will contact you directly and answer them. And also a big thank you to you, Leander, for your support today. So to all of you, enjoy the rest of your day wherever you are. Goodbye for now. Bye-bye.
Thanks, everyone. Bye-bye. Thanks, Carol Ann.